Thank you everyone for coming tonight. I'm so happy to have Katie Kelly here with me. So Katie is a pelvic floor physiotherapist. She did both her bachelor and master's in physiotherapy at Dalhousie. She owns her own private physio clinic in Moncton and is expanding, which is super exciting. So creating that Reconnect Health Center. We'll see your guys' updates. Katie also has a special interest in C-section rehabilitation and teaches courses to professionals. I recently took it. It was fantastic. Highly recommend. Katie has formed a relationship with the Mount Allison University's Sexual Health Laboratory to research chronic pelvic and genital pain conditions, which leads us to what she's going to be speaking about with us today, which is graded motor imagery for chronic genital and pelvic pain and penetration disorders. So before we get started, I just want to remind everyone, this is a webinar version of Zoom, so we won't see your faces, but there's a Q&A area where you can put in questions as we go along. And feel free, like while the presentation is actually going on, you can put your questions in there and I'll monitor them and let Katie know about them at the end. Just a reminder, this isn't a place to ask questions about like your specific issue, but if you can ask it in like a general sense and keep it on topic, then that would be great. And I'll ask a few questions at the end as well. We'll have a bit of conversation and then open up the floor. So, and if you have any general comments, again, you can put that in the chat area. Okay, so Katie, you can take it away.
All right, I'm gonna screen share here and just let me know when you see it. And then we'll get started. Can you see that?
Yeah,
okay.
It's in presentation mode.
Okay, so the research that I've been working on over the last couple of years is in regards to how women who have genital pain respond to imagery of genital pain. So the title of this presentation is Anxiety and Perceived Pain Levels of Women with Genital Pain in Response to Images. And this is what, you know, in the physio community, we're kind of thinking of it as a novel approach to genital pain, but I think as you'll see as I go through the research that maybe this is a strategy that's been used for a couple decades now. The actual research that is currently in progress and should be published hopefully soon is Anxiety and Perceived Pain Levels of Women with and Without Genital Pain in Response to Pain-Related Images, which is kind of a mouthful, but I have to give credit to the lovely people who work in the lab and the lovely researchers that have let me come and annoy them with all of my questions. But Bonnie Fisher, who is the lab assistant and deals with me on a daily basis, Dr. Natalie Rosen, who's out of Halifax, and she has a fantastic website. She studies a lot of pain in the postpartum community, and then Dr. Lisa Dawn Hamilton, whose lab we're working out of at Mount Allison University. So I absolutely have to give credit to those women. So when we're talking about genital pain, the names and the words of all of these conditions have changed over the years. So typically we'd hear it called vaginismus or vestibulodynia. Now we've changed to genital pelvic pain and penetration disorders, so GPPPD, which is what you'll see me use in this presentation, but it refers to vaginismus, vestibulodynia, vulvodynia, all of those genital pain type issues where you have a hypersensitivity of the vaginal opening with no identifiable cause. So you're not seeing anything come back on an x-ray, you're not seeing anything come back on an MRI, there doesn't seem to be any sores, there's no infection. So when you have that type of pain lasting longer than 6 months, and where pressure, touch, and penetration can cause discomfort, fear, anxiety, or pain, that's when we'd use the label as GPPPD. Clinically, when I see it as a practitioner, what I'm seeing is someone who has pain, anxiety, fear, or difficulty with sexual penetration, things like medical pelvic exams, tampon use. Sometimes they have pain with urination or defecation, wearing certain clothing, particularly if you're wearing denim and there's a seam that goes up the center in between your legs, or sometimes pantyhose can be uncomfortable, certain underwear can be uncomfortable, sometimes exercising can hurt, and prolonged sitting posture. So if you have to sit forward onto kind of the vaginal area, or some people will feel it a little bit further back towards the rectum. But those tend to be the clinical signs that we see in patients that present with this. The prevalence seems to be a little bit skewed. It's likely that this is underreported, so we're not getting fantastic numbers on this, but between 14 and 34% of younger women, and then anywhere between 6.5 and 45% of menopausal, postmenopausal women. So based on a prevalence of 7%, America spends up to $72 billion annually on the costs associated with vulvodynia or GPPVD. So this is a little bit of a complex pain explanation, but if I do my job really well, then the practitioners who are watching and the lay people who are watching should have an understanding of how pain works and how it turns into, or a theory of how it might turn into chronic pain. But there are 4 processes that make up nociception, and nociception is our sciencey word for some sort of painful stimuli triggering the receptors somewhere in your body, and then your brain, like that message being delivered to your brain and your brain interpreting it as pain. So what we see normally is that there's some sort of stimuli that will activate your pain receptors or your danger receptors or whatever we want to call those receptors that can feel sharp, that can feel inflammation, that can feel too much heat, too much cold. And that message would then trigger a transmission into the entry into the dorsal root ganglion of the spinal cord. So that's where it enters into the spinal cord. It goes up the spinal column and it will ping around in the brain in a couple of areas. The brain will decide how much pain you should experience, and that's where we have our perception of pain. The other really interesting thing that can happen is that you can have pain be modulated. So you can have almost like volume controls along the spinal cord and in the brain that can decide whether your pain should be more or less. And an example of that would be if you notice you have a bruise on yourself at the end of the day and you don't know where it came from. So something would have modulated it to lower the pain levels. So maybe you were distracted, maybe you were rushing, maybe something was more important, and the brain didn't rank that injury of you hitting into the door frame or, you know, scuffing your knuckles, didn't register that injury as being too important at the time, so you didn't feel as much pain. So we do have this ability to either amplify or decrease how much pain we sense. Now, what we think happens in chronic pain is that it starts off as this normal kind of pain signal system that we see here, but then over time, something starts to change, and you can see those changes happen in the spinal cord, you can see them happening in the brain, you can see them happen in the systems that allow for modulation. So it can happen all through the central nervous system. And when we see those changes happen, we call that central sensitization. So typically what we see is an overactivation of these pain pathways. So we see that a stimulation will come in, it will get even more attention as it comes into the spinal cord. It will crank up the volume, you'll get even more signals that go up to the brain. And then what happens is we have a poor ability to modulate or to turn down the volume. So in the end, you end up having pain signals that can happen even when the stimulus, even when the thing that originally caused the pain is actually gone now. And that's a little bit confusing, but an excellent example of this is someone who has something called phantom limb pain. So I was lucky enough to have a rotation as a student and working in the amputation clinic. And what you would see is people who've had an amputated leg, let's say, so at the knee, where they're missing their lower leg and their foot, and they'd come in and they'd say their foot hurt, the foot that they don't have. So at this point, we know that the stimulation in the foot is not there because the foot's not there. But because they still have the foot representation in their brain and the parts that used to control the foot are still in the spinal cord, they can still have a pain sensation that happens in that area. So what we would do for those people is that we would put them in front of a mirror. They would put their unamputated leg in front of a mirror so that when they looked in the reflection, it looked like the amputated side. And we'd have them do exercises and movement, or sometimes they'd get an itch. We'd have them scratch the itch on the leg. So it would look, I'll show you a picture. It looks something like this. So you can see that their full leg would be outside of the mirror, and they would look at the reflection and do movements with the reflection, and the brain would register it as the limb. I'm gonna go back so you can see that. So it was really, really interesting to me that this was something that was working, and it was tested. It was really, we would see this used quite often in people who had amputations, but also then they started to use this strategy in chronic hand pain and chronic foot pain and chronic low back pain. An example of this in genital pain is when a Q-tip hurts. So oftentimes we will do a Q-tip test, which is, providing we know there's not inflammation in a wound, we will lightly touch the vaginal opening with a Q-tip. We know that's not causing tissue damage. We know that's not causing direct implicit trauma to the area. It should not necessarily cause pain, but yet it does. So it's a stimulus that we know shouldn't be painful, but yet it triggers a pain response in the spinal cord and in the brain. And in fact, that's what we see when we start to study this information in genitals. If we do an MRI of someone, so if we take a picture of their brain, when we do that Q-tip, that cotton swab test, we'll find that the pain areas light up way more. And even if we do it so lightly that it doesn't cause pain, they still have their brain pain areas light up. This suggests to us that we've seen those neuroplastic changes. We've seen the chronic pain changes shift in the spinal cord and in the brain, so that now we know it doesn't even take a stimulus that we would normally consider to be painful to cause a pain perception. What's even more interesting is if you do an MRI on a brain in women who have genital pain, and instead of applying any sort of stimulus to the vaginal opening, we do a thumb prick. So we press their thumb where they don't have a chronic pain issue. We know that the thumb prick test will cause their pain sensory system to light up even more than someone who doesn't have a chronic pain condition. So this suggests to us that these changes have occurred throughout the whole nervous system. We can't just isolate it to the vaginal nerves. We know that the spinal cord has changed, the spinal column has changed. We know that there have been changes in the brain. Your brain is almost primed to feel pain a little bit more than someone who hasn't been living in a chronic pain situation. So this has all been very fascinating to me, that we've seen this research be studied now for about 20 years in lots of other body parts, but we haven't seen it in the genitals. So why do we care about all of this? We care about this because if we know that, at least to some degree, some of the pain mechanisms are coming from the spinal cord and the brain, then we need to be treating that. And maybe we need to be spending less attention on the tissues themselves where someone's feeling the pain. Now, I'm not saying to ignore those at all, because I do think we have to look at muscle tissue, we have to look at mucous membrane, we have to look at the nerves in that area, certainly. But some of those patients that keep getting chronic pain no matter what we do in the pelvic floor, maybe they're not having the success that we like, because maybe there's something in the nervous system and in the brain that needs to be tweaked. So what we're hoping for is that rehab, pelvic floor physiotherapy, can focus on reverting those maladaptive central nervous system changes. We can try to shift the nervous system back to where it was before. The beautiful thing about the nervous system, why we call them neuroplastic changes, is that they're plastic and malleable. If you've changed the nervous system to be oversensitive, then we have strong evidence to suggest that we can change it to revert back to what it was before. And one of the ways that we do this in other body parts is to use a technique called motor imagery. Motor imagery is where a patient looks at pictures of activities that would normally cause pain. So for someone who has chronic hand pain, they would look at pictures of hands in different positions. They don't move their hands. They don't do the pictures at all. They don't do the activities in the pictures. They just close their eyes and imagine themselves doing those activities. And what can happen with some people is that that can cause pain and swelling, just the sheer act of imagining themselves doing it. And as treatment, what they do is they practice that daily over and over again, and then they start imagining more and more difficult tasks, and what we see is an improvement. So that's what some of these treatments look like. Those are the flashcards that you can use for hands. They have apps on phones for it now too, which is nice. And that's what one of these studies is saying, is that just by viewing and imagining that you're doing an activity, we can see physical swelling that can happen. So we know that the brain and the spinal cord can control how things are feeling in a painful area. We know that if you do treatment programs that last anywhere between 6 to 10 weeks that we can see decreased pain, we can see decreased swelling, we can see decreased disability scores, and even on MRI, we can start to see the brain shift back to what we expect it to look like in someone who doesn't have chronic pain. So that's really exciting. So our research is looking at the very first step of this. Do women who experience penetration-related genital pain, so pain with intercourse, with pap exam, with tampon insertion, do they experience more anxiety? Do they anticipate more pain? Do they respond differently to looking at pictures compared to women who don't have genital pain? So we had 109 women participate. 58 of those were women that had pain conditions in the genitals. And we asked them to look at a series of 36 images, and we asked them after each picture, how anxious do you feel looking at this image? Imagine you're the woman in this image, how anxious would you feel performing this activity? And then imagine you were the woman in this image, what would you rate your perceived pain in this situation? And then we had them rate those answers on a scale of 0 to 9. So these are kind of a sample of the images that we used. We did use more graphic ones that showed the genitals explicitly, but I didn't put them on here just because. But they were pictures of walking, running, sitting in different positions, inserting a tampon, having intercourse. So having intercourse in a picture like you see here, where it's kind of implied but you can't really see, and then having very graphic images. And then the same thing for pap exams, like the image above, where it's implied that a pap exam is happening, but then we also showed actual pap exams happening. So our results. I know not everyone likes to talk about stats, so I'm just going to show you one. I'm going to show you how they responded to what would you rate your perceived pain in this situation, but we got very significant results across the board for all three of those questions. And what was interesting is that the images that demonstrated penetration did score higher for rates of anxiety and perceived pain. And our effect size, which is just a fancy way of saying how big a difference did you see between the two groups, was quite big. How big and how important did a difference? And we did have really high scores for our effect size. The other thing that I found really interesting was that women were able to look at the images that implied penetration, and they responded to them in a similar way as whether they were looking at the graphic penetration or not. And that makes a difference for us as clinicians, because I can tell you it is very difficult to find good graphic images of penetration that aren't very pornographic in nature. And what I mean by that, it's the images are usually very thin, tanned, hairless white women. So for us to try to find images that would demonstrate, and as an example, kind of different body types at different ages and different ethnicities, that's tricky to find. But it's easier to find ones that aren't as graphic. And I think to a patient potentially doing this as a treatment, it might be a little bit more palatable to not look at the graphic images. So we were happy to see that. So in our discussion, what we were talking about is that women with GPPPD respond to looking at pain-related images with greater viewing anxiety, anticipated and anticipated pain scores compared to their pain-free controls, which is very exciting to us because, to our knowledge, this is the first time that this has been done in a motor imagery perspective for genital pain. And what it suggests is that we're hoping to see similar results if we do the same treatment protocols that have been used on chronic hand pain, chronic foot pain, chronic low back pain. That we're hoping that the same results that we see with those patients might be applied to women who have genital pain. So that's what our next goals are for the upcoming research, will be to try to use this as a treatment method and to see if we can actually start to see those changes and start to have some improvement in our patients. So I'm happy to answer any questions. I'll run through the references here real quick in case people want to see them. I know we do have some clinicians here, but it's on video, so you guys can go back and look at those if you like. So.
Awesome. Thank you.
You're welcome.
That was fantastic. So again, if anybody wants to ask some questions, feel free to put it in the Q&A box. I'll start off with some questions, so maybe that can get the ball rolling. So first off, actually, I wrote down some things during a little bit. I thought that was like when I was going through your presentation on my own, I didn't pick up, and obviously I was going through it, rushing through it, but I didn't pick up as easily the implied versus the graphic images was pretty much the same. So I think that's really cool and helpful as a clinician, where it's like, okay, like I can just use the more implied photos for the treatment. So that's really
we were
cool.
happy to see that too.
For phase 2, when you guys do the treatment, are you going to test out both? Do you know yet?
You know what? We probably will if they let me. Because we have hired models. I have hired a vagina model to come in, so we do have images of explicit kind of vaginal penetration.
Yeah.
So we have the images. We'll probably try to use those, but we shall see. Yeah, I think it's an interesting fact.
Yeah, that's really cool. So tell me more about phase 2. What are you guys hoping to do? What kind of stage are you at in the process?
So in phase 2, what we'd like to do is to bring, I mean, we're still figuring out, and if you've ever designed a research project, you go back and forth a million times because you have to agree with what the ethics will let you do, and you have to do something that you can repeat the same way over and over and over again. So likely what it will look like is bringing women in and doing the Q-tip test to confirm they do in fact have the hypersensitivity at the vestibule, and not just having them verbally say that they do, so that we can confirm that. And then what we'll probably do is run them through the protocol where they have to look at a number of images on a daily basis and imagine themselves doing it. So that's the protocol that's been used for the hands, feet, and low back before, is that you pick a couple of images of activities that you would find challenging, but not so challenging that you can't imagine them without pain, because that is what happens clinically. I mean, I'm doing this clinically right now. We would just like to know that what we're doing as physiotherapists has some research behind it. So while it's been used in other body parts, it has not been confirmed in genital pain yet. So that's the aim behind all of this. But when I do this clinically, I usually have my clients pick between 3 and 5 images of things that they find that they would interpret as being difficult, and we start with the easier ones and they do that. And once they can visualize that without pain, then sometimes I actually have them physically do the activity. Like wearing jeans is a big one. A lot of women will come in, yes, they want to be able to engage in intercourse again or be able to have a pap exam, but sometimes it's little things like just being able to wear jeans. And I say to them, can you imagine wearing jeans without pain? And if they say no, that's where we start. So we'll have them practice imagining wearing jeans without pain. And then once they can successfully do that, I usually get them to start wearing jeans in 5-minute intervals. Can you walk around the house in jeans for 5 minutes? Can you sit in them for 10 minutes? Can you wear them out to the store and come back? And then we'll progress on to visualizing more challenging things. So can you visualize inserting a tampon? Can you visualize undergoing a pap exam? And kind of progress from there.
Okay, cool. So one of the first questions was how and when in the treatment process of a patient with chronic genital pain do you typically introduce this imagery treatment?
It's a little unusual, right? So I think that most patients coming in, I want to be very clear when I start with them that I don't think that this is in their brain, that I don't think that they're just making this up, because unfortunately, I think a lot of patients have been told by people before that this is all in your head. And to me, your brain is in your head and your nervous system. So it's kind of in your head, but it's really in your nervous system, and that extends throughout your whole body. So I try to check the muscles and do as much of the pelvic exam as I can. Some women are just anxious to get that part done with too. So we do, usually for the first treatment or so, I'll do that. But if I start to notice that I'm not seeing any improvement happening at all after I want to see at least some improvement after the first or second treatment. Or if I'm seeing a clinician who has already seen if I'm seeing a patient who's already seen multiple clinicians, then sometimes I'll start right with that. But oftentimes what I'll just say to them is, can you picture yourself having sex without pain? Can you picture yourself wearing jeans without pain? And as soon as they say, no, I can't picture that, then that's what would trigger me to start saying, well, it's actually, your body's very smart to say that. I'm happy that you're recognizing it. I think what we're seeing is some of those like I give them that whole spinal cord brain talk, and I say I think we're seeing some amount of that change has happened. And what I don't know is what percentage of your pain is still in the muscles or still in the periphery, and what percentage is in the nervous system. But let's not waste time. Let's treat both and see if we can start to make the changes happen faster. So that's typically how I have that discussion with people.
Okay, yeah, I think that's great. Okay, so then another question was on, would graded motor imagery be useful for such conditions as painful bladder syndrome or IC, which is interstitial cystitis?
Yeah. So yes, and I study it in a genital pain fashion, but I would highly recommend anyone who is watching this to go check out my friend who lives in England, Jilly Bond, because her specialty is bladder pain. And that's actually how I met Jilly, was we were both talking on discussion groups, on nerdy Facebook physio discussion groups. And she was talking about graded motor imagery for the bladder, and I talk about it for genital penetration pain. But yes, I think Jilly's job is much more difficult, because at least with me, for graded motor imagery of the pelvic floor of the genitals, I can see that. I can go get a picture of the pictures that I showed you. For bladder pain, it has to be much more visualized, because you can't just show someone a picture of their bladder, right? You either have to show them an anatomical drawing of what a bladder looks like. But yes, Julie has been successfully using this with bladder pain patients as well, absolutely. So I'm stealing from her, but I will credit her at least, is that she usually does a lot of imagery with descriptors. So she'll say things like, imagine that your urine is icy cold, or that there's a menthol coating around your bladder. So she'll try to trick the brain into giving more cooling, pain-free thoughts using descriptors, and she does a good job with that. She also does just start at the pelvis as well, which I sometimes will do too. If you can't have someone picture genital or bladder pain activities at all without pain, then sometimes just looking at pelvises. She has a lot of her patients watch, I think in Britain it's called Strictly Come Dancing. Oh, but yeah. It would be similar to our dance shows that we have here, where she'll have them watch that and just watch the pelvises. What I usually get people to do is I'll get them to get a magazine and flip it upside down and circle all the pelvises, just so you can trick your brain into looking at pelvises in that area without pain somehow. So that's kind of our cheat way to get in, is just start having people look at pictures that don't cause any symptoms at all, and get them to normalize bladder. Because I'll even tell people, when you're in a restaurant, watch pelvises, not in a creepy way, but if you're in a restaurant before COVID, when we were allowed to go out, watch how people walk and sit who aren't in pain, and just pay attention to that more. And then as that becomes easier, then you can start visualizing your own painful, challenging activities.
Yeah, for sure. I think that's great. Yeah, it reminds me, I did multiple rotations at the Children's Hospital here in Alberta, and they have a chronic pain program there. So I got to play around with one of the apps of the hands and the feet, and part of the process when you're looking at hands and feet is you have to, say whether it's left or right. And people with pain tended to get it wrong, which is interesting.
Yes, it is.
But then with a pelvis, you don't have left or right. So
right. So that's what I was just going to say to you, is that we've struggled, because that's why we're calling it motor imagery. Or sometimes I call this explicit motor imagery or implied motor imagery, because we can't do the left and right like you can in a hand. Although I am toying with taking vaginal pictures and tilting them left or right. So I have done that, but I don't have a timer set up on my computer, so I can't have that same response time. And you know what? I've had good results without having to do that too.
Yeah. I think just knowing the process is really helpful, and it's going to help all of us be able to put that in treatment-wise. So we've had some more questions. I'm going to leave the more research-based ones to the end, so I'll kind of keep it with this topic a little bit more. So one question was on what are your thoughts regarding the correlation of changes in the nervous system and chronic fatigue?
That's interesting about chronic fatigue, because when you look at research, the gold standard for our chronic pain patients to compare as a control is fibromyalgia patients. So because we're starting to think that fibromyalgia is probably also a central sensitization change that's happening. So I think that there is something associated with that. With chronic fatigue too, it's interesting because you will see a lot of anxiety, stress, like those will all become factors. So I don't know that I can tease it out specifically, but I think that there's a factor in there in that the more pain you have, it's so strongly linked with other societal things. So when you're in a lot of pain, you're probably not going to sleep well. You're probably not going to be exercising and moving as well as we want you to be. Going out and just having fun, like going out and interacting with people and socializing can be difficult because you're always looking to think, where am I going to sit? Where's the bathroom? Like there's a lot of other things. So I think the mental load that happens with chronic pain is very similar to what we see happening with chronic fatigue.
Yeah, and then another one is on, do you use questionnaires like the DAS, which is the Depression, Anxiety, and Stress Scale, or Central Sensitization Inventory to screen for central nervous system involvement in your patients?
So the short answer is yes. And actually in that research study, we used the pain catastrophizing scale and we used the McGill pain scale questionnaire as well. We didn't publish the data because it's already been demonstrated in the research over and over and over again that, that women that have genital pain tend to have higher scores. People with chronic pain tend to have higher scores, usually because of all of those secondary stressors that are associated with chronic pain as well. The long answer is sometimes I'll use those, but now the questionnaire that I more typically use is the Yellow Flags questionnaire that was made popular by Annie O'Connor. And the reason that I use that questionnaire is because I was ending up giving my patients 4 or 5 questionnaires to do, and it ended up just being a little bit annoying to them. And the Yellow Flags questionnaire for clinicians, once they fill it out, there's an algorithm that you can add up. And if they have like these questions at this score, then we know that it's probably kinesiophobia. So they're probably scared of moving. If it's these questions at this score, then we know that depression, anxiety, and mental health have a huge component in pain. And if it's kind of a mishmash of all these questions, then we know it's probably that central nervous system change. And allodynia, for the patients watching, allodynia is when you touch someone with something and it shouldn't cause pain and it does. So that Q-tip test is an allodynia test. If you have a positive allodynia test, it automatically lets us know that there's some sort of motor autonomic pain that's happening. So motor autonomic is your central nervous system and the way that your brain interprets pain signals. We know that something is off there already. So I usually screen through the Yellow Flags because it's one questionnaire, really, really fast. And then if I still can't suss out what the heck is going on, then maybe I'll add the other questionnaires on now.
Okay, that's really good to know. I've been hearing more about the Yellow Flags questionnaire. So
there's more and more. There was no one promoting it before, and now there's someone promoting it. So and they're doing more and more research with it because it's easy, it's fast and easy, like chronic pain for dummies. It's great.
Awesome. Actually, I'm just realizing, I think it was in your course that I saw that.
Maybe, yeah.
And then I was looking it up and I was like, oh yeah, this does look interesting.
But Annie O'Connor's done some really good research with that.
Yeah, that's awesome. Okay. So we have a couple, it looks like, more patient-related questions. So one person was asking if there was any at-home methods. So you had talked about, just watching pelvises and stuff and the magazines. Was there anything else that you recommend kind of?
So you can look for pictures if you want, but even if you don't want to do that, if you know that you've got 3 or 4 things that are really bothersome. So classically, I'll see women that have problems with penetration. So you're having pain with sex. Can you imagine one finger going in? And I don't care if it's your finger, I don't care if it's a partner's finger. Can you imagine that? And you have to imagine it from your own perspective. So it can't be like you watching you. It has to be you envisioning it inside your body. And I try to tell people with as much detail as possible. Can you picture where you'd be, what the temperature would be, what the smells would be, what kind of lighting would there be? And can you visualize whatever preliminary stage, can you visualize that? Can you visualize it without it physically causing pain? Because some women will imagine it and they'll get pain just from the mental representation. And then can you imagine it, even if it doesn't cause pain, can you imagine it at least not causing pain when you would do it? So usually I have them go through. So, I mean, it could take you like 30 seconds to a minute to imagine inserting one finger. I get them to do that 3 to 5 times and to try to do that 3 times a day. When that starts to become easy, then maybe we imagine 2 fingers, or maybe we imagine partner inserting a finger, or that's kind of the way, maybe it's a thumb and a finger, like just so that you're progressing to be more and more challenging towards what you want that ultimate goal to be.
Yeah, I like that. Okay, so then we also have a question about low estrogen at the perineum, and about like applying low dose estrogen, and they're kind of wondering, like, this seems like a band-aid and not getting to the root of the issue. I'm wondering if we can answer that in kind of a generalized way.
Yeah, I think that's a really good question. And I think it's useful for clinicians and patients, because I think what happens is someone has vaginal dryness. It depends on how long it's been happening for. So we talked about in that pain signaling system that an original insult, an original injury can be like, you could have had a yeast infection, you could have had a bladder infection, you could have had physical trauma to the area, you can have estrogen related vaginal dryness that made sex be painful. As women, what we tend to do is kind of grit our teeth and tolerate it and keep trying. And what happens when we keep trying, 3 months later, 6 months later, the brain has learned. I always say the vagina is really smart. Like, the brain has learned now, sex hurts. So when you go to have sex again, it's already waiting for the pain. The nerves are primed. We get better and better at feeling pain. So you can go on and treat. I encourage people to speak to their physicians and see if they're good candidates for estrogen, because we do want to fix that dryness. But if you've been suffering with the dryness now for 6 months, we know that you can start having those changes happen in the nervous system. So you use the estrogen and yet it might feel better, but the problem's still there. Now we might need to look at, well, maybe you have the learned habit of Kegling before you have sex because it's hurt for so long that you can't relax at initial penetration. But maybe you've actually seen those neuroplastic changes happen in the spinal cord and in the brain. So I would ask them the same question as I would with anyone. Can you envision having sex without pain, or whatever their goal is, and see if you can start to see signs of that neuroplastic change happening.
Yeah, I think that's great. I think like at the clinic, we often describe it as, you know, like we want to help heal things from the bottom up, but also from the top down. Exactly. And so sometimes a low dose estrogen cream can be really great to help from the bottom up, but then we have to often think about the top down as well. And as you said, depending how long it's been, I think that's great.
That's a perfect response. Yeah.
Yeah. Okay. Yeah. She wasn't sure why they were prescribing it, but cool. Thank you. Okay. So then we have another question. What are your thoughts on using distraction to lessen chronic pain?
It's another tool in your toolbox. So I think what we're trying to do is to gently expose our body to things that could be painful, so we can slowly build a tolerance. And distraction is a fantastic way to do that. I think that's one of the examples of what that I said. You can find a bruise on your body and not know why it got there. So distraction is effective. My concern with distraction is using it to an extent where it's actually ramping up your pain. And I will give a common example that I'll see in low back pain patients, where it's like, I just want to get the gardening done, and they focus on getting the gardening done, and they're able to do 6 hours of gardening, and then the next day they can't walk. So the same would apply to genital pain. You can use whatever distraction technique you want, but if you're using it and then overdoing what your nervous system and your muscle system can comfortably do right now, then it's a disservice. So it's just like all of our tools that we use. There's pros and cons. We need to use them in the proper dose.
Yeah, I think that's great advice. Okay, so it looks like we've got kind of the more specific chronic pain questions out of the way. So then Mercedes had a question about, she's curious about the process for getting ethics approval for this type of study, how you address concerns about provoking anxiety, were the subjects present with a PT or physiotherapist who could help with the increased pain and anxiety, or did they participate at home? Yeah, it's a highly sensitive topic, and so she's wondering, do you have any advice for ethics applications?
Yes. So I believe in our previous round of ethics applications, because it was originally done as an online study. So we had opt-out options at each phase, and we had to give resources for, if you do find that this is a trigger for something, then you can please check in with this resource, this resource, this resource. I think when we bring patients in, that we're going to be very clear about at any point of the research study, they can stop. Because I find sometimes once women get involved with pelvic exams, and it's interesting that she asked this because it was also a legal question that my lawyer asked when we hired our vagina model. How do you pay someone to model if you get halfway through a modeling job and maybe they become uncomfortable with it? So it's the kind of, we did it at each phase, you opted in or out, like, can we keep going here? And just to make sure that they're going to do it that way. And then probably offering treatment afterwards for people who are in the control group versus not, is that offering them whatever we consider to be gold standard of treatment.
Yeah,
that's probably how we'll get around it. Yeah.
Yeah, that makes sense. Awesome, thank you. Okay, I'm going to bring up my questions again. One of my questions is, what do you wish the public knew about research and the research process?
How long it takes. So it does take an incredible amount of time. And like, I think even a lot of clinicians right now want to know, why haven't I just tested greater motor imagery to begin with, right? So our ethics board said, prove that they even respond to images differently first. So we have to prove that we have a leg to stand on before I subject women to doing a full graded motor imagery protocol. So what they even might make us do before we go on to testing motor imagery would be bring them into the clinic, confirm with a Q-tip test that they do have pain, and do the exact same study again. So it will just depend on what, I think at this point, a Q-tip test is standard protocol in an obstetrics gynecology exam. So I think that we can probably get away with that because that is the gold standard for testing for this. So I think that shouldn't be too much of an issue. And I think there's now probably enough research demonstrating the benefits of graded motor imagery in other body parts. But how many steps, how many hoops you have to jump through before we can physically say, yes, this is what we think is happening. And the other thing is, normally in the clinic, when I do a session, I would tailor it to each individual. When I study it, I can't. So someone would come in and they would ask a question like, I can't answer that until after the study. I might want them to also do like muscle relaxation exercises or meditation, or I might think that they would be great at doing yoga, or maybe they should use estrogen. But if I'm just testing how they respond to images, I can't offer any of those treatments to them. Can't make any of those suggestions. I can't tailor it to be a very individualized program for them. So I think that's why we see clinically that we just start to use some of these techniques, because sometimes it can take a while for the research to definitively say that we have shown this in the research and the stats.
Yeah, I think that's a really good point, because, you know, it's like, why are we, you know, if only some people find it beneficial, but then you have to factor in, like, yeah, clinically we would be trying out lots of different things, but we still want some sort of evidence behind them. We don't want to just like throw caution to the wind and throw everything at someone. So,
and I have to find participants who are willing to do vaginal, like theoretical physio on them right now, right? So even just finding recruitment of people who are willing to volunteer. So when people volunteer for research studies, it is so huge, because we can't move forward until we actually have those volunteers come in and do the studies.
Yeah, that's huge. And to have both like the control and so for people who might not know, like a control group would be where like they don't have the condition, say like a healthy control. So yeah, it's something to always think about for people. If you want to help get research going forward, yeah, find out ways that you can get involved. And like, no matter where you are in the country, there's usually some research happening around you. Like if you live in a town with a university, like Mount A's and Mount Allison, St. Yvette, like over in the Maritimes, there's so many schools in these small towns, and, you know, it might not be the specific study, but you can see what's available. What could you help out with? Okay, so I'd like to know a little bit more about you before we finish.
What would you like to
know? So kind of like a little overview, like why did you want to become a physiotherapist? Why did you get into pelvic health? I know you got into it earlier, similar to me. And then...
Yeah, why did I? My parents asked me that a lot. Why are you doing pelvic floor physio? So I wanted to be a physiotherapist when I was a teenager because I grew up as a figure skater who was constantly getting injured. So I think by the time I was 13, I knew how to use a TENS machine and I knew what settings the ultrasound should be at. So I was like, this is great. I already understand it, which obviously I did not understand it at the time. But so I went through physiotherapy thinking that I was going to be a sports physiotherapist because I wanted to go to the Olympic and work with athletes. And then we're very lucky because at Dalhousie, what happens in your last semester as a senior student is that each week is a specialty. So you get exposed to obesity and diabetes and seniors and amputees, and pelvic floor was one of those weeks. And I found it very interesting that it was techniques that you'd used all over the body, but that could be applied to a muscle that we really didn't learn about much in school. And I was a little bit annoyed that the rest of my class didn't necessarily want to go do it. I mean, I can understand it's intimidating. And for the layperson out there, what you don't realize when you go get your certification is that you have to let the people also getting their certification practice vaginal and rectal exams on you. So it becomes being, I think, a bit of a barrier for why we see so few pelvic floor physiotherapists. But I did a senior rotation in pelvic floor physiotherapy, in breast health and pelvic floor physiotherapy. And I was hired by that same therapist when I graduated. So I went and got my certification immediately and started practicing part-time, and then realized how much women needed access to this. My part-time, a couple evenings a week became a couple days a week, became most days a week, became all that I do. So now I just work as a pelvic floor physio.
Yeah, that's great. Yeah, I can totally relate to people being like, why would you, like my entire degree, I was like, well, that's what I want to do. And they were like, well, why? And then as we got to the end, people were like, oh, I see. I can start to see why. Yeah, and there's actually a few of my classmates have gone into it, which is cool.
I think after women have babies, you tend to see them realize sometimes it's just an unawareness of all the conditions that can happen in the pelvic floor. And then once you start to experience them as a clinician, you feel, well, I should be able to fix myself. What do I need to know to be able to do that?
Yeah. Yeah. And then that's definitely where we see it a lot. Or I find like the other people, like they had those painful conditions and then they're like, oh yeah, well, I'm interested in getting more information out there.
Yeah.
So then why did you want to pursue research?
I love to teach. So I was a figure skating coach. I was a dance teacher. I come from a long line of teachers in my family. I really just like to teach. And I've had good teachers. So I was introduced to graded motor imagery in a pediatric hospital as well. That was my first exposure to it. And then I got to work with amputees and saw it there. And then I was attending a course as a pelvic floor physiotherapist when we first started talking about all of the new literature coming out about chronic pain. And they made the joke, wouldn't it be funny if we did greater motor imagery on the vagina? And I was like, that would not be funny. That would be amazing. That was in 2015. So then I started figuring out how, as a clinician, how I could start doing research. So I started pestering people who worked at universities.
That leads me to my next question is, how do you balance clinical work and research?
I don't. I just work all the time. I'm lucky. I really do. Like, I love this job. It's my hobby and it's my employment, which is fortunate. So when I get sick of charting, because I think I've got a short attention span. So as soon as I get sick of doing something, I'll just move on to something else. So So the research started to be my hobby, but that's also why it's taken me about 4 years to publish this, is because I have to pick away at it. When my kids are asleep at midnight is when I'll be typing and researching and reading. And for every one article that I include as a reference in my research, I've probably read 25 other articles that didn't work with the research. So I just keep picking away at it. And I was lucky to have a local university that had a sexual health lab. So that was fortunate for me.
That's great. I didn't know that Manning had that, but that's fantastic.
Yeah.
So good to collaborate with those people. Okay. So then we had one final question come up about, oh, hold on, check this here. Okay, so first one, I already know what the answer to this is going to be, but other than motor imagery, have you ever used mindfulness and meditation in treating chronic pelvic and genital pain?
I do, because as I said, in my clinical world, I don't usually ever just give graded motor imagery. I usually assign this with other things. And I'm a firm believer that women have a difficult time understanding how the pelvic floor works because we don't get to see it ever. So it's not like an arm, right? If I tell someone to straighten their elbow, they can straighten their elbow. And if they didn't know how, I could show them with mine. I can't do that with the pelvic floor. So when I say, I need you to relax your pelvic floor, first of all, what do I even mean? It's almost like I've asked them to grow a third arm out their belly button and to throw a fastball with it. Like, just realizing that those muscles do things is one thing. And then the pelvic floor, we know from research, is strongly related to stress cues. So if you're someone who clenches your jaw, if you're someone who can get really into their work and get distracted, we know that you're probably, at least to a low degree, squeezing the pelvic floor muscles readily throughout the day. So just building an awareness, and you can do that through many different techniques, but one of those would be mindfulness, one of those would be meditation, down training techniques, pelvic floor relaxation, behavioral change, that sort of thing. So they're all tools.
Yeah, so many tools. Yeah, and that's something I like to say is that, like, I may recommend meditation, but I also want to figure out if it's right for that person, because like some people just hate meditation, and that's okay. But
I'm very bad at meditation.
So many tools, and that's the point. You don't have to be good at it.
Yeah. So you got to figure out what someone is able to do. I could design the best physio program in the world, and if they hate it and don't do it, doesn't matter how good a job I did. I have to find a program that's going to work for them.
Yeah, totally. Okay, and then what are your top resources on this topic? By the way,
you knew.
Yeah.
You know what I'm going to say.
What is it? Go ahead.
The NOI group. So NOI, have the NOI group, is who came up with graded motor imagery. And I really should give credit to David Butler and Lorimer Moseley, because they are brilliant human beings. They are basically the fathers of modern pain science, and how we as clinicians in medicine and physio and chiropractic and massage, how we study pain these days. They have oodles and oodles and oodles of free information on their site. For clinicians, if you're interested in graded motor imagery at all, they have the Graded Motor Imagery Handbook, which is a reasonable price, I believe, and it goes through in great detail how you can do those protocols. So I strongly recommend you read that. Jilly Bond has lots of free information on her website as well about that. And there's also an app. What's the NOI group app called? Do you remember? I'm just gonna look it up here.
Oh, I don't know if you have it.
Recognize. It's called Recognize. So they have Recognize foot, Recognize hand, Recognize shoulder, Recognize low back. Mm-hmm. They don't have a genital one, and I've talked to some of the instructors from the NOI group. They don't intend to make one, but if you look and see how it works, what's interesting about the Recognize app is that if you buy one of them, you can add your own pictures. So what I sometimes get people to do is just take pictures of pelvises of their friends and family, and then they can load it into the slide. But you can make a PowerPoint presentation of it too if you wanted to.
Yeah, for sure.
But, and Lorimer Moseley's TEDx Adelaide talk. So if you just put into Google Lorimer Moseley TED Talk, he gives a fantastic talk about how chronic pain works. And he's really entertaining. He's way better at me than teaching all of this. He'll make you laugh, and he makes it under really easily digestible, but that's a great 15-minute talk to watch.
Yeah, he has so many. There's some great ones. Yeah, I'll always remember that with the snake.
Yeah.
yeah, there's so many great resources out there. Once you start digging into chronic pain, it just like, there's tons. Yeah. Okay. So I think we've gotten through all of the questions. For anybody who's still wondering what resources, we will send more in the follow-up email. And you can always watch this again to find. So there will be a replay available, which is great, even for those who weren't registered. And so then final question would just be, how can people find you? So whether it's patients, professionals, anybody interested in being involved in future studies?
Yeah, so they can find me at www.katiekellypt.ca. That's where I post when we are running research studies, so you'll see them there. I have a lot of information on my website for clinicians and for patients, and I'm on social media as Katie Kelly PT as well. And then for pregnancy or postpartum people, we have a company called Motherhood Link, and that's where we post lots of free information for women who are pregnant or postpartum, because we found we were getting lots of questions and we just wanted to kind of divide up the two. So women who are pregnant could just head straight to the main site of Motherhood Link to get the information that they need.
Yeah.
But that's where you can find us. Yeah.
Yeah, that's great. And then you also have your C-section course on Embodia.
Yes.
Which is fantastic.
And I do give it live, hopefully again sometime.
Again one day. Yes. Oh, yes. And like, you have lots of great information that I think is very related to this topic in there, even though it's about C-sections, but a lot of it is very applicable for this work too.
Yeah, we use the same technique on C-section scars as well.
Yeah. So then I want to thank everybody for coming. So again, so I'm Christine and I work for Vida Health and Wellness. So we're the ones hosting this. So we're here in Calgary, whereas Katie's over in Moncton, which is so fantastic that we could do this like east-west collaboration. And we're actually planning to do more of these. So keep your eyes out. We don't have any planned yet, but we will. So we want to, lots of different topics, whether it's like mental health or other physio-related topics. And if you have anybody that you would like to recommend, then like you guys can feel free to send us an email or contact us on social media. I think there's just so much great research out there, and I think we need more people that can bridge that gap between patients and just regular people who are interested in this, as well as clinicians and other researchers. And the more we can kind of start to realize just like the process of research and all of its hoops.
Well, and I think that we need to give patients, like, give them the benefit of the doubt that they can understand this. If we can't make them understand this, then we're not doing our job well. So we need to understand this inside and out so that we can explain this to a variety of education levels. And so if patients don't understand why they're getting pain, it's really hard, as we know, because the brain is so involved with it. We can't help them to the degree that we should be able to. So it's on us as well that we need to give them the credit that they can understand all of this. Absolutely.
100%. Yeah. Just because this might not be somebody's, area of expertise, but they can still learn about it. And often just learning about it, is a huge help in their pain. So
yeah, absolutely.
Yeah, just knowing about that. Okay. So thank you so much for joining us, Katie. And thank you everybody for joining us. We'll sign off and everybody can expect an email and the recording and things in a few days. And yeah, I look forward to meeting you in person one day, Katie.
Yes, let's hope.
Okay, bye everyone.